Dr. Glass, what role, if any, for pharmacists is there in difficult conversations paradigm?
Thank you. If you can find a pharmacist who's willing to have a conversation with a patient, I think that would be great. I think they have a lot of credibility. They obviously know the pharmacology. And in Washington State, I know they have certain abilities to talk to patients about medications that they can dispense without a physician's prescription. So they may be getting training in this area as well.
Did you want to add anything, Laura?
We actually have pharmacists who manage our opioid program and do have these conversations, and it's really helpful because for a non-prescriber to have the conversation is always easier than the prescriber themselves.
Thanks. Did you want to add anything, Laura? Okay. Dr. Weimer, go ahead.
I was just going to say I've been working with folks at Kaiser in Portland who had successfully deployed a pharmacist-assisted opioid taper program that they've been running for at least 5 years. And we're trying to do some retrospective study on that. So we have a perioperative program at the UW. David could talk more about. And then this Kaiser program was more about longer-term outpatient opioid users. So at least in terms of pharmacists' broader role in opioid taper, I think there's a bunch of interesting models out there, and it is a valuable thing to do.
Yeah, and I just, whoever asked questions, good call out. They are an essential part of both our inpatient and outpatient pain delivery service, and it brings pharmacists up to full scope of practice. So it's extremely satisfying for them. In fact, we're training pharmacists now who are coming through instead of doing a formal internship. That's part of their rotation. We're getting great response from our patients because they can talk to the pharmacist when I'm not around or one of the other faculty's not around, and they're really engaged in it. So this is a really great opportunity to consider in your health systems to incorporate pharmacists directly on the front lines. They are really build the full multidisciplinary team.
Anybody else? Did that answer? If you didn't answer your question, you can gesticulate wildly, and I'll come back to it. Let's ask Dr. Weimer. I think this one's for you. Since buprenorphine is used for pain, maybe it's not. Maybe it's a broader question. Since buprenorphine used for pain is 8 to 10 times safer than methadone, why is it not the primary drug of choice for those who fail to be tapered? Has CDC created a de facto upper limit?
I think you could say that it is a safer alternative for patients who are failing a taper. Certainly what I generally recommend, so if my patient's on a high dose and they're not doing well, having a lot of depression, anxiety, other symptoms, then generally I do recommend that they switch to buprenorphine as the treatment option. And I think, for patients who have chronic pain, in my mind, it makes more sense for them to be on buprenorphine than methadone. Patients, as Jane was saying, they don't really fit into the category or feel that they fit into the methadone category, and many of them will be quite offended if you were even to suggest they go to a methadone program. Certainly access issues can dictate that, and I do think that if you don't have any access to buprenorphine, methadone may be the only option in some cases. But I think that it should be an essential option in a way. I sort of feel like if you prescribe opioids for chronic pain, you should also prescribe buprenorphine, so that if your patients have trouble with their opioids, you can then offer them treatment for the opioid use disorder that may have occurred. And I think that's our duty as primary care doctors. And just to let you know, I have a primary care panel, so I can say that with confidence, as well as treating addiction, but happy to hear what other panelists think.
I can jump in. We've done probably just 3 of us now, Jay, myself, and Jim Robinson, are Suboxone X licensed, so we're making certain we're covered when we're managing this. But in my experience, I have about 16 or 18 patients I've converted with Some of them are on that gray side of addiction, and others are really pretty close to the well-behaved patient, and the craving and their inability to get the drug requirements out of their head every day was driving the factor. And I have to look at the data, but I'm over 95%. This is the best thing you ever did. It just totally changes the interaction in the room. Tapering them down off, that has not been the goal, but we do try, and that doesn't go quite as well. But it's a tremendous tool, and the barriers we've heard are the PAs can't prescribe on my behalf when I'm out there. They can do everything else. They can prescribe OxyContin at the unbelievable methadone, but they can't prescribe buprenorphine. A big barrier, and the nurse practitioners in the state of Washington and in the whole country are not allowed, and that has to be changed, and at the governmental level. For pain, but the dose you get with the Butrans is not, and then if you prescribe for pain, most insurance companies in Washington State won't cover it, and that's $400 a month or more for most patients. So there's the barriers that were well outlined are a major problem, and hopefully that will change in the next year. We're working with the governor's office here. We're going to do some more talk at the governor's office here to move that as an insurance expectation that they are going to cover. If they're going to cover oxycodone, they will cover buprenorphine on any indication, even if it's off-label.
Jim, do you want to get in on this?
Yeah, I just wanted to say that for those of us that are at these roundtables with our various senators and congressmen, I would bring that point up over and over again. We've got to get PAs and nurse practitioners to prescribe buprenorphine, and I think they're beginning to hear it. There's a lot of pushback. I don't completely understand it from Samson. Maybe you do.
No, well, that was my. Sorry, can I tee that question up? I don't understand the pushback. Listening to all of you who actually know what you're doing, it seems to me that we ought to be much more broadly using buprenorphine, and that we should not be all that worried about it any more than we are worried about pharmacological decisions, basically. So, okay.
I could just say the prohibition against NPs and PAs prescribing is federal, and it requires legislation to change. The administration, through a regulatory change, can lift the cap, but in order to allow NPs and PAs to prescribe in states where they're allowed to prescribe Schedule IIIs, you would need legislation, and there's a bill that's been introduced both in the House and the Senate, and so there's an effort to make that happen, but the state can't allow NPs or PAs to do it. It has to be done on a federal level. But
so we heard from Senator Merkley when we were in a roundtable with some folks here a couple months ago, as well as a treatment doc out on the coast who accosted a colleague of ours at the summit we did there with tales of abuse and risk of buprenorphine. And Merkley wasn't, to be clear, he wasn't articulating this as his view, but saying, I keep hearing.
Yeah, so I think the diversion of buprenorphine has to be put into the appropriate context. What should really concern us is if diverted buprenorphine is creating new cases of addiction, and if people are overdosing and dying on diverted buprenorphine, that would be making our opioid crisis worse. I think it's unlikely that diverted buprenorphine is creating new cases of addiction. If someone who's a young person who's never had an opioid before makes the mistake of experimenting for the first time with buprenorphine as opposed to, say, Vicodin, it's a very aversive effect. It's very potent. They get a pounding headache. They're sweating. They're nauseous. And unlike a Vicodin, where even if they didn't like it, it's wearing off in a few hours, they're feeling lousy for 8 to 12 hours, maybe even longer. There seems to be very little recreational use of buprenorphine among people who are opioid naive. Where it's abused is in correctional settings, for example. If it's smuggled in and someone is an experienced opioid user and they take it, they're going to feel like they just took a strong opioid. But most of the diversion appears to be people using it in a somewhat self-therapeutic way. And the irony is that all of these restrictions really make the black market worse. People can't get it from doctors and they're buying it on the street. And so with regard to creating new cases of addiction, I don't think it's really doing that. And because it's difficult to overdose on, there are very few reported cases of overdoses involving buprenorphine. Sometimes it's an incidental finding in a medical examiner report, but overdose deaths are uncommon. So I think there's, you've got policymakers out there acting like we've got an epidemic of buprenorphine abuse. We have an epidemic of opioid addiction, and Alkermes, the maker of Vivitrol, is partly playing this up. They're doing this in Washington. They like to tout extended release naltrexone injections as being better than buprenorphine because there's no diversion, and I think they're possibly making this worse.
Interesting. So a couple of questions about sleep hygiene, mostly directed to Dr. Halban, but not exclusively, I think. What do you do to improve sleep hygiene in pain control? How do you get your patients to sleep when most meds for sleep are relatively contraindicated with opiates?
Let me do the easy one. The last part, Mark looked at me when he used nortriptyline because when I joined the University of Washington, my nickname was Dr. Nortriptyline because I was prescribing it as first-line therapy because it is very effective for sleep and is contraindicated only at very high dose methadone because of QT issues or an active arrhythmia or on any significantly prolonged QT interval drug. We give it to heart transplant patients with full clearance. So all that worry of a little TCA. And the biggest problem is, unless you got gray hair, you've never prescribed tricyclics because you were not trained to do it. Our psychiatrists teach our students never use these drugs because they're way too hard to use. And I think don't forget Flexeril, cyclobenzaprine, is one hydrogen molecule away from amitriptyline, so it's a tricyclic antidepressant drug without any proven antidepressant benefits. So we've been doing it all the time and haven't realized it. So the easy one is I use TCAs. The truth is, I say we need to have you talk with a sleep hygiene expert, and we have a nurse specialist who does the work. I give a handout, and a session is scheduled to talk about no blue light, the bed for only sleeping and amorous activities, restriction of alcohol, restriction of caffeine. It's kind of the standard litany that you're all familiar with. No bright screens before you go to bed. And I run through that, and they, get glazy-eyed because I'm talking so fast. I give my handout, and then I refer them to the nurse where the heavy lifting gets done, and that's an efficient way to do it in our practice.
I'm concerned about the used to be tricyclic overdose that was non-treatable.
It's a great question, and when I did my residency at the University of Washington, half of the patients in the medical ICU were tricyclic overdose deaths. So ARDS, the whole thing, it was a mess. So I am very sensitive to that. We were giving doses of 100 to 200 milligrams a day for depression. You need pretty high doses for the patients who are getting those doses. I remember giving amitriptyline 350 to 450 milligram doses. To get them to sleep, it's 10 milligrams or 25. So it could take almost a whole month and be equivalent to what I used to give for a single day. 30 years of practice, 0 issues with a TCO. Now, that's anecdotal, but that's not an issue that I hear come up in any other conversation. Melissa, your primary care experience?
I think, sleep hygiene is definitely important. I think many of them don't have any routine either. I also ask them how many naps they're taking during the day or how much they actually are sleeping during the day. And I usually find that they actually are sleeping the majority of the day and up the majority of the night. Part of that is because they're completely inactive all day long. So we talk about increasing activity, even small activity, or getting out of the house, the social isolation as well. If I was home alone and my kids weren't running around me, I'd probably fall asleep too. So, making sure they're getting out of the house, doing activities that are enjoyable. That's the other thing. I find that many of them have no quality of life because they actually have no hobbies any longer and they're not doing anything that they enjoy. So, playing up that I think is important. And then I screen for sleep apnea and find that many of them have pretty severe sleep apnea. So going through that litany of changes, and once you treat that, their sleep can really improve, and they actually have consolidated sleep and quality sleep.
Yeah, so let me just carry this further to be more helpful like you were, rather than turfing it to someone else to do. The CBTI, cognitive behavioral therapy for insomnia, evidence-based, more effective than any drug, the Z drugs, the benzos, everything else we give. Several recent evidence to support that. There's an app for that. It's called sleepio.com. Great reference, endorsed by a couple of CBTI providers, sleepio.com. There's a small fee. It's like, to get the app, it's a few bucks. And patient report on that is very positive in terms of just, again, self-management. You'll learn how to do it. The key is when they come back, I make a note in the chart, recommended sleepio.com app. So the first thing I do when they walk in to see me, I say, how did that sleepio.com app work? Because our problem is we don't follow up, and if we don't talk about it, they don't think we think it's important. So that's the number one conversation I have. How did that app go? And they go, what app? And I go, well, let's go back through this again. It's important. I bring it up until they actually get engaged. I actually went through the app, so I know a little bit about it, so then I can ask them, what did you think about the scene in that? And if they don't know what's happening, I embarrass them a little bit. I say, why don't you take a look again at it? So it's, it's like recommending 12-step. You should know what the steps are, so you can ask the people to let you know that they're not just dumping it off, that it means a lot to you as the provider, that this is an important thing to do.
So we had a separate question about sleep hygiene for patients in MAT. Is that answered, or is it a different approach?
I think it's a lot of the same issues, though I will hear people say a lot of times, particularly in the methadone program, that they have withdrawal at night, and that's a problem with sleep. Methadone lasts so long that there can be issues with withdrawal, particularly in the initial phases. But I think to Jane's point about tolerance, a lot of what we see are other things that are reducing their tolerance or putting them into withdrawal, like anxiety or other things that they're actually interpreting as withdrawal because of their profound opioid dependence. So we work on it, but we also know that sleep is really difficult to get managed in early recovery. So we counsel patients that might be difficult, give them a sleep aid of some kind that's safe, try to use melatonin, other sleep routines, sleepy time, tea, whatever they can do to try to promote sleep. But it can take a while to get that leveled out, for sure.
Anybody else? Is there a good means for identifying long-term opioid users for chronic pain with permanent neurological changes that make them less capable of tapering?
Literature's at that point yet.
Oh, I thought Mark.
No, I defer to you, Jane. You guys want to whisper in my ear and then I'll say something?
I mean, you don't have to accept the premise of the question that there are people, right?
Well, if I don't quite understand the question, but if the question is, can you identify people who are at risk before? Is that the question?
The question is, are there people, let me remove the premise and ask it more open-endedly. Are there people who undergo neurological changes as a result of their long-term dependence on opioids for chronic pain that render them less capable of taper?
Yes. Yes. So I think that's what I was offering as a primer to Mark's taper discussion, that there are profound changes, in fact, that make it very difficult to taper in a lot of these patients. Not all, but in a lot of these patients it's very hard because of those adaptations. And some of those adaptations are not reversible, so even when you succeed in tapering, and so you get to the end of the taper and you have someone whose head has cleared, they say, as Mark says, no longer in a zombie state, their family thinks they're much better. Even though you've achieved that, they're still at risk of relapse, and they often do relapse. And that's why the enduring adaptations that occur, which are essentially memory, which is always difficult to eradicate memories, but in this case it's memories combined with drug use, so they're inseparable. The circumstances of the drug use and the drug use itself means that these remain vulnerable individuals. So there are significant changes, neurological changes, that are quite difficult to reverse. And they make tapering difficult, but they also leave people vulnerable to relapse.
Yeah, so I just add, as a primary care provider, I've got 20 plus years of experience, 25 with some of my patients. I think you just have to go slow. Mark talked about you can pause 6 months, and you could drop it by 1/5%, and just keep that curve down, and over 5-6 years, you can pull the taper off. You just have to hang in there, be resilient, and don't ever go back. And if there's a new injury, a 2-week bump, and back down. And there's other things that happen, there's reasons to go up, maybe, and if you do that, it's always back to the previous dose. You just have to steady on the rudder, no matter what the storm is ahead, and just keep it slow and straight. I think the people that are at high risk for relapse, that's an excellent indication for buprenorphine. I think that's oftentimes when I make the decision, let's go on buprenorphine, because they've just been on it so long and they've got these chronic changes, and it's just safer and provides some analgesic response as well, a substantial analgesic response as well.
I handed Dr. Sullivan the next question because it involved a drug I couldn't pronounce.
So this is nortriptyline again?
Okay.
So what dose and for how long and who is what the question is. So I would use it in situations where even prior to opioid taper, somebody has depressive anxiety or insomnia symptoms. They're facing an exacerbation of anxiety, insomnia with the opioid taper, and here they're telling us they're having struggles with that already. And I start people at 25. I'm a little more dosing aggressive maybe than David, and go up by, I don't think I got anybody above 75 in the trial. And I think that tended to keep down those symptoms, to the point where people could tolerate it as they went through the taper. So not huge doses. And some of the people were already on other antidepressants, and sometimes I did other things depending on what they were already on. And how long? I don't know. Certainly through the taper period. I think people are going to face challenges during the taper, immediately after the taper. If somebody asked me, how long should I stay on these? I would tell them 6 months to a year. That we really want you feeling better, doing better, back up to freeway speed in your life before you taper these off. And I always suggest that patients, at least try a month at half dose before they taper themselves off, to just see if they can't tolerate having the dose, they're not really ready to tolerate stopping the dose either. It's a sign that you do need it, it is helping you, and it would be unwise to stop.
Just a comment, if they have neuropathic pain, it's the drug of choice, so you may want to use it persistently as a chronic therapy. That certainly makes...
Could be a substitute therapy, also shown to work in musculoskeletal pain, so it might be a long-term strategy.
Just one point on nortriptyline, and I think it was mentioned before, but I'll just emphasize it. If you do have a patient who's suicidal or a patient with a history of suicide attempts, you probably don't want to give them nortriptyline because it is dangerous and overdose. So that's one of the main benefits of SSRIs over tricyclics.
Downside is SSRIs have no analgesic evidence for effectiveness. So, but SNRIs make sense. That would be a good alternative, but they don't help sleep. Yeah, so it's all the tools.
Dr. Sullivan, not to pick on you, but while we're on your topic, did you look at the effects of depression during tapering? Did you measure depression during tapering as part of the study?
Yes.
Yeah.
Yeah, I showed that.
I thought so. Okay. So we can. The slides will be in the packet, and on the website you can check.
Yeah, the important thing is that it did go up and down for different people for different reasons, but on the whole, it improved. I'm not sure it's on the edge of statistical significance, but the mean at the end was lower than the mean at the beginning. So it's not true that everybody went through the roof.
Dr. Weimer, why don't you try this one and see if we can have other opinions too, of course. But does medical marijuana have any role in pain management?
What?
Melissa loves it when I give her this
me?
question.
This long.
That's because I'm picking the questions.
I think it can in some cases. So there are different properties of marijuana. There are euphorogenic properties, and there tend to be some pain relieving properties, particularly in marijuana that's high in CBD. So I have seen some patients recently benefit from using high, or what is reported to be, I should say, high CBD concentrations of marijuana. The reason I say reported to be is because when you go to a dispensary, they will tell you the formulation of the marijuana, in whatever form, if it's edible, tablet, dab, whatever, smoked. And there have been studies that have looked to see if there actually are the thing that they are described to be, and 99% of the time they are not. So I do counsel patients about that, that you can't be sure that what you're getting or buying or told is exactly what it is. But for somebody who, doesn't have a substance use disorder, I'm not concerned about them developing a substance use disorder. They want to avoid opioids. They are functionally doing well. They're doing well in their life, and they choose to consider marijuana to see if it has pain relieving property. I don't tell them that they shouldn't. I let them make the choice of whether they feel comfortable doing that or not. And some of my patients have reported getting good benefit from high CBD containing products. One patient in particular who was refractory to all other treatments, not on opioids, but refractory to all other treatments, did really well on a very low dose CBD type tab. So I have seen it work in certain instances. Where I don't see it work is in patients who use or smoke marijuana multiple times a day, that keeps them in a sedentary fashion and an obese fashion, and not able to engage with life and developing problems. So I think if they're using it to be more functional, and they are actually being functional and not being sedentary, engaging with life, then I think it could potentially be an effective therapy. But it still remains controversial, and unfortunately we don't have any good studies to show us whether it really works for many of the chronic pain diagnoses that are out there. It has been shown to be effective in MS, and I believe there's one other condition. It's had some decent data.
Neuropathic pain.
Neuropathic pain.
The American Pain Society is promised a position paper, big review. There was an hour-and-a-half symposium on it just a week or so ago. It's finally clearing. I think it's about to be out, or is going to be out imminently, which the discussion was very balanced, pros and cons, and a thoughtful discussion, and several of the authors of that policy recommendations is going to be down the pike. So stay tuned, and maybe that could be added to as a resource. Mark Stevens to the website once the APS cannabis paper is out, to just better understand the debate. I think it's an open question still, how to use it and when and for whom.
I live on the Oregon-California coast, and I've seen a number of patients who have initiated this on their own, particularly the older patients who are tired of the opiate side effects, and now they can even go to Oregon if they don't have a medical card in California to get their marijuana. I've seen a couple dozen people who have done that themselves in the last year.
And there was a study showing that in states that had legalized marijuana, there were reduced opioid deaths or opioid overdose deaths. So I think we're just beginning to understand how it might help. But I think you just have to be careful about how your patient's using it and if it's really helping them with a functional gain, because that's really what you're monitoring with any of this therapy.
I'll just make a comment. In the context of our opioid crisis, you're hearing from the pro-marijuana camp that marijuana is the way out of the opioid mess. And there was even a paper in JAMA. I'm surprised it got published, but because it really made no sense. But they showed that states that had passed medical marijuana laws, like Washington State, didn't have opioid overdoses increasing at the same rate as states that hadn't passed medical marijuana laws. The study didn't really make much sense because there were a lot of other things happening in these states, and there wasn't evidence even that docs were prescribing marijuana instead of opioids. But you have the pro-marijuana camp saying this is the way out of the opioid mess, and you have the anti-marijuana camp saying that marijuana is a gateway drug and would make the opioid problem even worse. And it's hard to really...
Yeah, the bottom line is we're now going to find out. You know.
Actually, bottom line is the next administration, because it's all determined by the Attorney General, and it's chosen by the President, who has been, we're not going to focus on this, we're going to let the states manage it. But that could flip, and then it becomes an illegal drug, because the DEA is under the authority, we have an attorney here, I shouldn't be saying it, but I say the DEA.
You have the right to remain silent, David.
Yeah, the DEA is, stop me when I'm going to get it wrong.
Yeah, well, someone asked me about it earlier today, and my sense actually is even with President Obama, whose experience with marijuana is very different from a lot of us in law enforcement, I'll put it that way. Even with him at the helm, my sense is that neither the Department of Justice nor DEA have any sense of humor about marijuana at all. And I don't see in a Clinton administration or a Trump administration a significant change. I guess a Trump administration, gosh, I can't believe I'm saying those words, but here we are. Right? I guess that they could go back further from where we are, but I don't see a significant change imminent. Now, you know, Congressman Blumenauer, who's my congressman, I live in Southeast Portland, so you have 12 patients, I have 12 neighbors on my block, right? I don't see big change on this anytime soon. I do think we're going to get data, and we'll maybe be able to make some choices based on reality as opposed to on speculation, whether it's reefer madness or reverse reefer madness, which we've kind of bounced between the two, as far as I can tell, over the last 6 decades. All right, let's move on. Here's a question that I think kind of goes to the nub of, Jim, what you've been trying to do in this community, and really, for those of you who don't know, what you have done here is being modeled all over the nation and all over Oregon, literally with other communities tagging Jim to come and tell him how you do it. So it's something to be very proud of. Is it reasonable to maintain a patient on 40 to 60 MED long-term, they are tolerant, so safe, in parenthetical, when attempts to wean further lead to increased pain complaint?
You mentioned that my name, but I'm really not sure I'm the one to answer the question, and I'm kind of interested to hear what other people think about it as well.
I'll say that if the risks do not exceed the benefits, and that the functioning and the quality of life is improved, and their treatment adherent, I don't see a problem. And if the underlying diagnosis, the pain diagnosis, is not one that would disqualify them for being a candidate, and that is headache, fibromyalgia, and nonspecific back pain, and probably chronic unexplained abdominal pain syndromes. If they don't have those, and it's working, and there's plenty of people out there with musculoskeletal and post-traumatic syndromes, post-cancer survivor pain syndromes, where there is indication that nociception is still going into the system, it is appropriate. I've heard that, I think Michael Korf is in the audience, I think 1 out of 7 patients on opioids in a little pilot looked like they were not getting into trouble. Whether they were benefited is up to you as a clinician to see evidence of that with evidence-based tools that can record that, at least in a patient-reported outcome format.
I'll just make one quick comment, because I also want to hear what Jane and Mark have to say about that. Just one point, and Dave and I were talking about this last night. You know, I'm not in favor of forced tapers, and if a patient seems to be doing okay, and then I wouldn't necessarily force them off. But you know, because a patient is doing okay, who's a patient on long-term opioids, that doesn't mean they're doing okay because of the opioids. I think they're doing okay despite the opioids, and I think that's an important distinction.
And I would like to just clarify doing okay. I mean, we're grappling with this exact question in our clinic vis-a-vis policy. David and I and Jane are on a panel trying to decide when we're going to bless low-dose opioid therapy. And all I wanted to say is that doing well is doing well. And a lot of times patients will say to this, they may say, I've got 9 out of 10 pain, I've got, significant depression and anxiety, but I would be much worse if you took away my opioids. My sense is that to be doing well on the drug, you have to be doing well. Like, you have to have a good mood and good function, and you're succeeding at, most importantly, at the important roles in your life. That's doing well. Somebody who says, well, I'm in bed most of the day, but I'd be in bed all the day if I weren't on opioids, that is not a good candidate. And those people should either be tapered or transitioned to buprenorphine.
Thanks for getting me out of the hole then, Mark.
Well, I was just going to say that it really, you need to make the distinction between somebody who isn't being treated and someone who's got there because they've been treated and because they've been treated for years. In other words, if someone has already developed opioid dependence, you're often not treating pain at all. So the pain really doesn't matter because you're not treating pain, and the pain will be what it's going to be. What you're treating is dependence, and so your clinical decision is what's the best way to treat the dependence, which, as we've all discussed, sometimes it's abstinence, sometimes it's maintenance, sometimes it's switching to buprenorphine or methadone, but sometimes it's just continuing the opiate they're taking at a reasonable dose and just keeping an eye on them.
I do actually want to jump in on this. So the other piece to consider, though, is to be sure that the opiates are going into the body that you think they're going into. So if you're going to do that, then I think you really have to be sure you're doing due diligence in all the appropriate ways. Urine drug screens, PDMP, pill counts, informed consent. And if you do it to everybody, we all are concerned about singling people out and making them feel bad. But if it's your routine, just be sure you're doing your routine with those individuals.
So, unless it happened when I was out of the room, we didn't hear too much today about naloxone and coprescribing. The CDC has some very general guidelines on when, a component of their guidelines as to when coprescribing is indicated. Do any of you have anything to add to what the CDC has to say about this?
When the idea of co-prescribing naloxone to patients on particularly high doses of opioids, when people first started talking about that, PROP actually had a conference call, and one of the concerns that was raised was that if you have a patient on high doses of opioids and you're concerned that they're at risk of an overdose, rather than co-prescribing an overdose antidote, why don't you lower the dose, and which makes a lot of sense. And so that was the argument against co-prescribing. But as we really talked it through, well, for one thing, as we all know, lowering the dose is much easier said than done. And as I think was mentioned today, I think you mentioned this, Dave, co-prescribing is a teachable moment. When you're bringing the patient in and a family member and you're saying, I'm so concerned that you may stop breathing and die, so I'm going to co-prescribe an antidote, that I think does help encourage patients to taper. So we did ultimately at PROP feel that this was a good idea and supported that CDC recommendation.
And it also gets more naloxone out in the community.
Right.
And the CDC is specific, high dose. They don't say what.
Yeah.
You get to pick the high dose. Sleep apnea, history of opioid overdose, which I think is an indication to not ever prescribe opioids, just way too risky. And sleep apnea. I think they call, if I recall, 4 specific high-risk circumstances as examples when it should be considered, as they put it. I think it absolutely should be done and reflexively done. It should be built into electronic health records So when any of those are present, sleep apnea is a diagnosis, history of opioid overdose is on the list of previous diagnoses, and the MED exceeds 50, 90, I'm not sure.
Boom.
It alerts patients should be co-prescribed naloxone, and then you go and it's there, and you click a button and you sign it. It should be easy to do, not impossible, which is how it's currently arranged.
I've been taken by this fascinating experience in Fort Bragg, North Carolina, where lots of people jump out of airplanes and get injuries, and they had a very high overdose rate among soldiers. And so they started co-prescribing, and sure enough, they saw the overdose rate come down, but not because people were using naloxone, but because they were being prescribed naloxone, and that conversation of, here's an opioid, this is a dangerous drug, you need to be careful, so I'm also going to give you the overdose antidote, had the impact of bringing down the overdoses. I think it's fascinating.
Yeah, they're studying this at the University of San Francisco right now, from work being done in the medicine clinic at UCSF, to see if that conversation changes the behaviors and dose outcomes of their population.
Actually, on the other side, I mean, the concern, certainly when we started doing this, was would it produce complacency? So say, well, we're okay, we'll stay with the high doses because now we've got the antidote, so we don't have to work so hard on reducing the dose because we've got the antidote. And the other concern is that it's not likely to save as many lives of pain patients as it does of illicit users, because pain patient deaths are not witnessed. And illicit users' deaths are witnessed, so their buddies know when they've overdosed, and they know how to intervene.
Right, and it's more common.
And so do the police on the streets. So it's very effective in those venues, but less effective for pain patients because they're often die in their sleep and nobody notices or watches them, often on their own. So, but it's still good to prescribe for the reasons we've all been saying, because it alerts people to how dangerous the drugs are they're taking.
Is there now a, quote, nationwide epidemic of untreated pain, unquote? Was there in 1995?
I say there's now an epidemic of poorly treated pain and inadequate access to the treatments that are proven effective. So I'd say it's still overtreatment with opiates, but untreated pain following the models that we all know well, and I think Kevin described since 1969, when the first multidisciplinary pain clinic opened, and it perverse incentives and all sorts of complicated reasons, mostly money, not surprisingly, ended. So we just need to get that back as an option and in your community in some form.
We have actually the nation's expert on the epidemiology of pain in the audience. So I don't know if Michael von Korf would want to answer that question.
Well, yeah, I think without a doubt.
Pain.
Probably, about 10-15% of the population are really impaired by pain. So it's a big problem. And the question is, if you can do things for people and make them better, that's a good thing. But not all problems have easy solutions. So this is clearly a case where, out of good intentions and compassion, a lot of harm has been done. The 100 million number is, there's 100 million people that have chronic pain. 40% of the population, chronic or recurrent pain. But the percentage of the population that are really, have difficulty major difficulties with life activities is probably more in the 10% range. That's still a very big number.
Actually, historically, this whole thing started with palliative care and the treatment of cancer pain, which was undertreated, and there was, and opiophobia had a lot to do with the undertreatment of pain at the end of life and cancer pain. And it was the palliative care specialists who succeeded in changing people's thinking about using opiates for the treatment of cancer pain, who were the main promoters of using it for chronic pain, actually, because they got the bit between their teeth, and they decided that since the suffering of chronic pain patients was equal to the suffering of cancer pain patients, we should extend this treatment to chronic pain. That's how the whole thing started, which is interesting. You look back on it, the individuals that were the main promoters were all palliative care specialists.
It's interesting also, as a mirror image to that, it used to be that I would never talk about prescription opioid epidemic or challenge without saying, I'm not talking about cancer pain. Because if I didn't, someone would yell at me appropriately. But now that's all woven into the conversation we get there. Yes, ma'am.
I just wanted, this was on the question you guys had, the one before last, but for you that are prescribers or have patients in your practice that are on opioids, when they have come into the ER for an overdose, and there's a statistic out that was published not too long about the percentage of people that come in as overdoses and go back to their doctor or provider and get this and continue to get those prescriptions, do you stop them right then and there? Do you switch them to some zone? Do you say that, how do you handle it?
Well, I have the benefit of working both in the hospital and in the outpatient setting. So I usually get to see them in the hospital and have a good intervention with an alcohol and drug treatment trained social worker. And we stop their opioids and we say they're not going to continue. It's not safe for you to continue to be on these medications. We'll discuss buprenorphine as an option, but quite frankly, I have never, knock on wood, had a patient overdose that I'm aware of on opioids. Several of my colleagues have, and I have to tell you that even in the times that I see them in the hospital and I say, we need to stop the medicine, there's this other option, generally they go back to their primary care doctor, and even though we might have had a long intervention, the primary care doctor still feels like there's a question. Maybe I should restart their opioids. No, you're not going to restart their opioids. And you really have to kind of hold their hand through it and offer them. And so sometimes the intervention or the starting of the buprenorphine or the ongoing conversation is most important, not necessarily even in the hospital, but in the weeks after the hospitalization when they kind of realize like what's happened and they go back to the situation that was promoting their ongoing use or led to their overdose, and that's where you really have to kind of be able to support them through that and assess where things are. So a real case that I just took care of a patient who had a stash of methadone, 300, 400, 500 tablets of methadone that she was taking sort of willy-nilly as she wanted, overdosed, and she went back to her provider who was on the coast, and I said, you know what? And she said, I'm not going to restart. I know that. I talked to the PCP. I said, you're not going to restart. He said, great, I'm not going to restart. I said, but you know what? I'm going to see you in 2 weeks, and we're going to talk about this again. And I want to know if you've really restarted at that point or what's going on. And at that point, maybe we need to reconsider buprenorphine. So I keep the door open, and I expect that it's going to be an ongoing conversation.
Yeah, so I want to just follow one thing. We've been working in Washington State with the BRE Collaborative. I'm looking right at Mike right now, Mike McCorf, who just spoke a minute ago. So one of the goals is to be able to communicate. You described you were aware of the overdose, you're involved in the care. Most of the time, this isn't even communicated to the primary care doctor. The patient doesn't report that. It just disappears in the record. So a system ought to be placed. I'm going to get into health system stuff. The system ought to be in place that the primary care doctor or the prescriber, as demonstrated by the prescription monitoring program, is notified.
Well, the way to do it is to get it onto the PDMP, and then if it's a state where docs have to look at the PDMP, they'll see if a patient had an overdose. That's being proposed, I think, in New Jersey, so that you'll know if your patient overdosed.
So you got to know, and then you got to have that, go to that course tomorrow to learn how to be able to take the difficult conversation.
Yeah, I'll just comment on this question. I was going to mention that, so I'm glad you did. I talk a lot about what I call a parallel process, and what I mean by that is just the difficult emotional nature of this work. And oftentimes, I think what you would see with a provider who has a patient who's gone to the hospital or whatever, who's overdosed and comes back, and they begin prescribing again, I think you really have to we would be wise to be, as providers and as people who are coming in touch with providers, to be encouraging people to look at what I call blind spots. So what is going on for that provider that they're not able to see the safety issue that's going on. And I will be talking about that tomorrow, and I certainly am happy to talk to people about that individually, because I think sometimes that can feel really vulnerable for people to start getting into those places in themselves.
So I think a major problem in the treatment of chronic pain, when people are sent somewhere else other than to the primary care provider's office for care, is a lack of coordination of care. There's virtually, we have pain clinics in Washington State, and what happens is folks go to the pain clinic, they're there for about a month, the primary care doctor hears nothing at all during that time, and then the patient comes back and often says, well, I still have pain, which is actually quite common. The primary care doctor who caused the problem of high-dose opioid prescribing in the first place goes back to prescribing more high doses of opioids. So coordination of care is really, really important.
Well, I think we're going to say thanks to the panel. We really appreciate your being here. Jim, amazing work getting all these folks here.